Liebe Kolleginnen und Kollegen, liebe Freunde des Amos Studientelegramms, Marcus at home welcomes Dr. Isaac C. in Atlanta, Georgia, with whom we would like to discuss burning issues in the field of thrombosis and thrombocytopenia syndrome after COVID-19 vaccination. Now, Dr. C completed his residency in internal medicine in 2011. He was an epidemic intelligence service officer with the CDC from 2011 to 2013. And being currently a medical officer in the Division of Health Quality Promotion, he has been deployed to the Clinical Immunization Safety Assessment Project, which focuses its work mainly upon TTS, again, thrombosis and thrombocytopenia syndrome after COVID-19 vaccinations. My co-moderators are Dr. Schirmer from Kaiserslautern in Germany, Anja Scheuer from Frankfurt in Germany. My name is Gunnar Heine, again from Frankfurt, Germany. It's a pleasure to have you with us, and thanks a lot for taking your time to answer our questions, Dr. C.
It's a pleasure.
So I would start with a brief question upon nomenclature, because it's somewhat difficult for us. We are discussing a disease which has been known since March or April, and which has already received 3 different names. So it was initially known as VIPIT, then the term VITT came here in Germany and Norway. Now in the US literature, you refer to this as TTS, thrombosis and thrombocytopenia syndrome. Are we talking about one clinical disease, or are these, in your eyes, different things that happened and that should have different names?
Okay, I think we are talking about 3 different names for the same clinical syndrome, and I'm realizing interesting that I guess in Germany and Norway, even with in the different languages, the abbreviations are still VITT in those languages as well. So I think especially some of the earlier literature used this term VITT, vaccine-induced immune thrombotic thrombocytopenia, after some of those first papers had come out in the New England Journal of Medicine from Germany and Austria, from Norway and from the United Kingdom, talking about patients with thrombosis and thrombocytopenia after receiving the Oxford AstraZeneca vaccine. This group called the Brighton Collaboration has now published interim case definitions, and their name for this syndrome was thrombosis with thrombocytopenia syndrome, or TTS. And so the Brighton Collaboration is a group that standardizes case definitions for pharmacovigilance activities internationally. And so for, at least in the United States, the CDC and Center for Disease Control and the United States Food and Drug Administration have chosen to use the Brighton nomenclature for the topic. But I think these are different terms that people are using for the same kind of clinical picture.
So you would recommend us to use the term TTS also here, because it gets easier to understand issues if we are not talking with different names about the same thing, actually. Huh?
Yeah, I'm not sure how the difference in nomenclature is going to be resolved. So
in most cases, it's the American who will decide. So anyway, we will follow your recommendations, I guess. Huh?
Yeah. Even in the United States, I think there are some of the professional organizations are using some of the other abbreviations. So we still maybe have some way to go in terms of harmonizing the nomenclature.
So our second question would be surely the incidence of TTS, because we were kind of surprised when we saw the first European data, and I personally was mostly surprised by the Norwegian data with around about 130,000 people vaccinated, mostly young women, and 5 cases of TTS, so around about 1 in 30,000 people. What are your ideas in the States? Do you see similar numbers, or is it less often with the Johnson/Johnson vaccine that it's used in the States?
So now I'm trying to do this math, and I'm glad you gave those numbers for because I haven't followed some of the incidence rates as closely for the AstraZeneca vaccine in Europe. It sounds, so if you said about 1 in 30,000, so that's That's about, well, that's probably then about 30 per million or so. So far in the United States, at least as of last week when we were looking at this, when we last formally looked at this and provided the information, in women for the Johnson & Johnson vaccine in women between 30 and 39 years old, it seems to be about, so we've been talking about cases per million vaccine doses. So that's about 12 and a half, 12.4 cases per million doses of the Johnson & Johnson vaccine for women 30 to 39-year-old. That is the group when we look by age group and by the patient's sex. That is the group with the highest rate. So for comparison, in men 30 to 64 years old, the rate is more like 1.3 or 1.4 cases per million doses. We have not yet had any confirmed cases in people over 65 years old in the United States. And I think also to mention, because I think if I was reading correctly, the Johnson & Johnson vaccine is not yet rolled out in, at least in Germany, right? It's approved, but maybe not available currently. So just so that people know that Johnson & Johnson is a one dose vaccine. So when we talk about number of doses, that should be the same as the number of people.
All right. Well, thank you, Dr. Say. It's a great privilege. Appreciate to have you with us. Going from the epidemiology right through to pathophysiology, obviously one gets questions, and we're trying to understand and compare both the rate of these sort of things happening and the pathophysiology behind it. Can you speculate on why we have been seeing that with vector vaccines only so far, and if or why there are possibly differences in occurrence? Dr. Heine mentioned the very high rates we've been observing in Norway. As far as I know, in Germany it was quite a bit less. What you're now alluding to in the States, the Johnson & Johnson incidence rate seems to be lower. Do you think it's due to the DNA, it's due to the vector? Do you see any causal relationship at all?
Yeah, so I think the pathophysiology, certainly we're still trying to understand what the pathophysiology is, probably really for both this TTS with both vaccines. So there are some various hypotheses, and it seems that there are some maybe hypotheses that in the literature maybe kind of leading hypotheses. I think in general, the leading hypothesis is that this TTS is following a mechanism that is similar to what people with a condition called autoimmune heparin-induced thrombocytopenia, or autoimmune we call HIT, have, where they develop antibodies to that can generate platelet activation and thrombosis. Normally, may be seen in patients who have been exposed to heparin, but in this case, in people who have never received heparin. So, for example, I think Andreas Greinacher, who's a German scientist and an international expert in HIT, has proposed that maybe there's a component of the AstraZeneca Oxford COVID-19 vaccine that might take the place of heparin, such as free DNA, such as maybe the DNA in that vaccine to sort of generate a mechanism like HIT. The WHO Global Advisory Committee on Vaccine Safety has, they've stated that a platform-specific mechanism for the syndrome that's related to the adenovirus vector can't be excluded, but it is interesting to note that although the Johnson & Johnson and AstraZeneca COVID-19 vaccines both use an adenovirus vector, the actual viruses that are used in those vaccines are different. So Johnson & Johnson uses a replication deficient human adenovirus vector, and the AstraZeneca uses a replication-deficient chimpanzee adenovirus vector. I think in terms of causal association, the U.S. Food and Drug Administration has already made a statement that they think that a causal relationship is plausible for this what we are calling in the United States TTS following the mRNA vaccine. I think it is certainly very, it's interesting to think about when you try to put the pieces together because, so far we have not had any confirmed cases of TTS in the United States after mRNA-based COVID-19 vaccines, and we have many more doses of those vaccines that have been given out to people. On the other hand, we have seen that there are case reports of thrombosis, including cerebral venous sinus thrombosis and thrombocytopenia in patients with COVID-19 infection. Although we don't have some of the details, at least reported, about some of the testing in those patients that we would have liked to have. So these are some of the pieces of information that we kind of have to look at to think about what may be common between some things and not common between other things, and kind of where people kind of in the lead seem to be thinking these days.
You mentioned the cerebral sinus thrombosis, or the location in rather rare locations of typical thrombosis, and obviously we're being asked that all day. And are people at risk for a regular normal thrombosis, at higher risk for the TTS? Apparently, they're not. What's your insights into this very special location? Why is that only the fact that it's not actually proper veins, that the cerebral sinus is not a regular vein, that it's that the disease appears to manifest there, or does that have to do with the pathophysiology as well?
I think it's not clear. It's not clear to us why there seems to be a high proportion, very high proportion of the reported cases that have the cerebral venous sinus thrombosis. Both, our paper that was published, of course, focuses only on cerebral venous sinus thrombosis, and the initial reports from Europe of this syndrome after AstraZeneca vaccination. Also, a very large proportion of the patients had this thrombosis. I mean, I can say that we do now. I presented last week at the Advisory Committee on Immunization Practices that we are seeing patients who have what you might call thrombosis in more common locations with thrombocytopenia, and some of the suggestive laboratory testing results with positive platelet factor 4 heparin ELISA results in people who after getting the Johnson vaccine, although it still does seem to be mostly the reports that we have are at least what's been kind of confirmed, what we call confirmed, has been mostly the cerebral venuses. But it's not really clear why so many more there than, for example, even other unusual locations like the portal vein, hepatic veins, other mesenteric veins, for example.
Hello from me as well. My questions would be about diagnosing TTS. So when should we suspect TTS? Are there any certain clinical symptoms that we should be looking for if someone is presenting with a headache? And what are some laboratory markers that we should get at first?
Yeah. So, I think that the suspicion is very much centered around, matches the, I think what the syndromes are that we're, kind of thinking about in patients. So we're looking at, of course, the thrombocytopenia, and then, thrombosis at potential different locations, such as cerebral veins, pulmonary arteries, mesenteric, splanchnic, abdominal vessels, as well as extremities. So I think so. The symptoms would, when we have looked in our paper of cerebral venous sinus thrombosis cases, we saw that the onset of symptoms was between 6 and 15 days after vaccination. Now we have seen some, as I said, what we call confirmed cases that have where the symptoms began a little bit sooner than that. But I think in general, we're talking about patients who have delayed onset of persistent or severe headache, persistent abdominal pain, matching thrombosis in location in those cerebral or abdominal locations, as well as shortness of breath or chest pain, which signs of pulmonary embolism, or leg swelling, I guess extremity swelling as well. I think we've seen primarily lower extremity swelling in patients without some predisposing factor for an upper extremity thrombosis, and easy bruising or petechiae that may indicate presence of thrombocytopenia. I think one of the things that we have in the United States have tried to put out with some of our messaging is that the timing of the headaches that we are seeing in patients with cerebral venous sinus thrombosis seems to be different from the headaches that normally occur, that commonly occur after vaccination. So many people develop a headache shortly after vaccination. As an example, in the JohnsonJohnson phase 3 clinical trial, headaches generally usually start within 2 days of the vaccination and also generally resolved within 2 days. And our initial 12 cerebral venous sinus thrombosis patients all had headaches that started 6 or more days after vaccination. In general, were persistent. Many were severe. I think the other piece that maybe not everybody thinks about is the importance of getting a vaccination history in patients who are presenting potentially with some of these symptoms, which probably prior to this was not going to be a routine part of everyone's interview with the patients and obtain the history. So in patients where this is suspected, I think we would suggest that imaging that's appropriate for the symptoms that are presenting in the potential location of thrombosis, as well as a complete blood count and potentially fibrinogen and D-dimer levels would be part of maybe part of an initial thought, as well as looking for the getting the heparin P4 ELISA test.
Okay, that would have been my next question. Is now that we have a strong suspicion that it is or it might be TTS, which confirmatory test would you recommend? Because if I remember correctly, in the case reports that you published, they all had a positive ELISA, but they had a negative HIPAA test. Is that correct?
This is sort of this is a little complicated. We are seeing, and maybe just to make sure that our audience is familiar, because I think in our team and many others who I've talked to, we start getting into the tests related to heparin-induced thrombocytopenia. Many people who are not hematologists are not so familiar with these. So to give a brief overview, the heparin P4 ELISA is looking for the presence of antibodies to platelet factor 4, or a complex between platelet factor 4 and heparin. And those assays then look for the presence of antibodies. Then if you are normally working up a patient for HIT, you would also get what would be considered a confirmatory test for HIT, a class of tests called functional platelet HIT antibody assays, which look to see whether the antibodies that you have seen that are present actually can activate platelets in the presence of heparin and lead to platelet aggregation and thrombosis. So in general, for HIT, that condition, the functional platelet tests have a higher specificity than the ELISA, and they're typically positive in patients with ELISA results with an optical density of at least 1 that kind of will vary between the assay. So for HIT, the functional tests, as I said, are considered to be sort of the confirmatory tests. It's a little less clear for TTS, I think, what the functional assays are giving us. And the reason I say that is in the initial 3 New England Journal papers describing patients with TTS, when I looked just to compare the patients with CVST, cerebral venous sinus thrombosis, 88% of those patients in Europe had positive results for functional platelet tests, versus in our patients, in our initial 12, we only saw positive results in 1 out of the 9 cases, patients who had functional testing done. And it's not totally clear why there is this sort of discrepancy between the United States and Europe. We wonder if the negative functional assay results that we see in our cases may be false negatives, and it's not, as I said, it's not completely clear at this point. But we do see that we have a very high proportion of cases from the U.S. now. Last week at our immunization advisory committee meeting, this was presented publicly, up to 28 confirmed patients with TTS. 26 had ELISA tests done, and 24 out of those 26 had positive results. So that test does seem to be very sensitive and a kind of a good marker. I will mention that there is a paper that actually just came out, was released 4 days ago, from a group in the United Kingdom, the same group that originally described their TTS cases, that looks at a comparison for different types of tests in patients who had been suspected to have TTS in the United Kingdom after getting the Oxford AstraZeneca vaccine. Although for the United States, we don't have that kind of recommendation after the Johnson vaccine.
Okay, thank you. Maybe as a last question from me, do you know about any risk factors that for the occurrence of TTS? Have they been identified yet?
We've definitely seen, and I guess as we talked about earlier, the highest risk, in terms of the number of TTS cases per vaccine doses in the United States seems to be, after the Johnson COVID-19 vaccine, seems to be in women under 50 years of age. Beyond that, to us, it's not quite clear what other risk factors there are. We have the CDC in the United States has put out a statement that all patients should be aware that there is a risk of having TTS after receiving the vaccine, but that especially women in that age group should be aware of the risk. We can note that half of our patients in our paper had obesity. One of them was taking, and one was taking oral contraceptives, which traditionally those are risk factors potentially for getting a cerebral venous thrombosis in general. But we don't yet know if these are actually really specifically risk factors for TTS or not.
So I would maybe end up by one final question, which is quite important for our understanding. I think you told us before that there have been some cases of thrombosis and thrombocytopenia in patients with COVID-19, so not with vaccination, but with disease. Do these patients also have HIT antibodies? Does this in some cases also kind of represent autoimmune HIT, or do we just don't have any information on these single cases?
So, so I'm aware of a small number of case reports of patients with specifically cerebral venous sinus thrombosis and thrombocytopenia with COVID-19 infection. And as far as I'm aware, what has been published in those case reports, and because this, of course, long predates the discussion about TTS and vaccination, that those patients were not reported to have been tested for, at least with the ELISA test. There are reports of positive ELISA tests also in other patients who have COVID-19 infection and thrombocytopenia. Some of those patients are also reported in the literature to have negative platelet functional platelet activation tests. So it's not clear really if those are related to what is happening with the vaccination, or if we have kind of, because clearly I think it's recognized that COVID-19 infection itself is certainly a prothrombotic state, and whether that is related to this or if it's a separate phenomenon is not really clear.
Yeah, so thanks a lot, Dr. C. It was a pleasure to talk to you, and we would recommend all our colleagues to look into your JAMA paper, which really gives a brilliant overview of all the cases that have been reported so far. We guess we will see an update in some weeks or months or so with the next cases which will come up. Until then, thanks a lot for taking your time, and have a good day and a nice weekend in Atlanta. Thanks.
Thank you.